Happy Thursday, everybody. You'll hear me whispering throughout because I'm at the airport, heading to Wisconsin to do some medical nerding out, which I'm very, very excited for. But honestly, I think that I'm just as excited, if not more excited, to be with my CP Songus family, especially because today is an all internal affair. We have everybody who I know and cherish hanging out in the lukewarm seats. But let's just be honest. Today, I'm going to be a side player in the conversation because I get to finally been a while, probably a couple months, go discuss again with our beloved Kirtan Patolia, who is slowly but surely taking over my job so I can retire, sit back, relax, and reverse osmosis. So let me hand the mic to Kirtan to say hello.
My friends, thank you for the kind words, Ravi. But friends, if you join CP Solas, you will realize that in CP Solas, there are different milestones that you need to achieve. Like you need to be on podcast, you need to be part of the leadership team. But still, the biggest milestone and the most coveted one is getting a chance to discuss with Ravi on Thursday. Because if you just like in fun put your name on the sheet to discuss with Ravi on Thursday, it will be deleted automatically. Someone will delete it. No one knows who is that person because
It's
they'll be
me,
like,
it's me.
do you deserve it? You don't deserve it. Then why are you doing this, right? Yeah. So it would be like, doesn't work that way. So I'm glad that today I'm getting that coveted chance. So Ravi, you got caught.
I did get caught. I also will say that perhaps in my vengeful state at 5:30 in the morning, will emphasize that the only person who's ever done that is you, my friend. So you too have
Yeah.
been caught. Kirtan's enthusiasm to go discuss is palpable. I'm sure nobody would doubt. Yeah, sorry,
Yeah.
Kirtan, but I'm
Yeah.
glad I'm
No.
glad we can have it today.
Yes. Yeah, thank you so much. And also I'm excited today because like my dear friend Manaswini is presenting the case and we know that all our CPCOS members are lucky that everyone puts so much effort to presenting the cases. But we know that Manaswini always takes a notch higher, that the slides she prepares for the rapid fires and the amount of hours, like sometimes she will text me that, oh, Ketan, we really like tomorrow's case. It's going to be a doozy. So it feels like she's putting days and days in preparing the cases so all of us can learn. So very grateful for Manaswini to be here. How are things with you, Manaswini, today?
That's too kind of you, Dr. Kirtan. I'm just thrilled to be here presenting a case to two masterminds who have like really set the bar incredibly high for not just being great at great clinically, but also such kind humans. And also thrilled because I'm presenting this case in between your grand rounds. Do check out Dr. Kirtan's grand round on last Friday and Dr. Rabi's that's happening tomorrow. And I just want to say you inspire and impact literally everyone you come across, and we're just incredibly lucky to have you and Dr. Rabi and you. Yeah.
Thank you so much, Manaswini,
Oh,
for
you made
presenting the
him
case.
blush, Manas, when you see he didn't know what to say. Congratulations. You officially stumped Kirtan, not diagnostically, but emotionally.
Yeah, that is true. Perfect. And finally, Eugene, who is helping the center. Eugene, how are things with you today?
Hey, Keita. Yeah, I'm doing great. I think Manaswini has said it all about the two of you, yourself and then Dr. Ravi. I mean, I was telling Dr. Ravi about how much he has made a lot of impact in my life. And I remember in my interviews, even for residents in the US, I had people mentioning his name and where I ended up starting to start my intern year. I mean, the program director said something very amazing about Dr. Ravi. So that's something I'll tell him in person. I'm just keeping that until I see him in person to tell him. So yeah, he's been an amazing person, very great discussant, impact a lot of knowledge to us, and I'm excited to describe him for today's case.
Thank you so much, Eugene. So, Manaswini, whenever you are ready, we can get started.
Yes, absolutely. So this case comprises of just four aliquots. And so here goes the first one. There's a 53-year-old gentleman who presented with complaints of abdominal distension for 2 months and shortness of breath for 15 days. So he noticed the gradual abdominal distension for the past 2 months with no associated abdominal pain. And he's a farmer, and he expressed that he slowly progressed from being breathless after working in the field for over 3 hours to being short of breath while even walking to the field from his house. And he had to take multiple breaks during work, and it was affecting his performance. And he also complained of 3 episodes of black tarry stools in the past 15 days. There's no complaints of hematemesis, no chest pain, no palpitations. And he's a farmer growing rice and millets and also works as a construction laborer. So he drinks around 180 ml of whiskey daily for over 20 years. And I would like to also give you the exam. So his pulse is 110, a respiratory rate of 26. Blood pressure when he came in was 92/60. But he came in walking, and his SpO2 was 95% on room air. There was pallor, and icterus was present too, and there was some dilated neck veins. JVP was raised, and S1, on CVS exam, S1, S2 was heard. Ejection systolic murmur was there, and they were in the aortic region, and pansystolic murmur in the mitral region. And then we did see some amount of hepatojugular reflux. On respiratory exam, there were some bilateral fine crests in the infrascapulary and infraaxillary regions. And there was some soft, mild, distended abdomen. There was no shifting dullness. And he was conscious, oriented with no deficits. And that's my first aliquot. Would love to hear the discussion.
Oh, thank you so much for starting with this part of the data massive. Like, I was like, why do you have only 4 aliquots when first aliquot itself has like so much data in here, like very complex case, right? And it makes us wonder that we are dealing with two main problems, right? That's something which has been brewing for a longer time, like 2 months, and something which started in like last few weeks, and then now like maybe something emergently happened within last few hours itself, right? And we are trying to establish whether all these 3 events are linked with each other by a temporal sequence of events, or they may not be linked with each other, right? So if we just try to understand the host rather than coming to the acute presentation right now, is that firstly, who is this gentleman, right? We know that this gentleman is a farmer, he works there, but we don't know about the immune status of the host. So down the line, we will come to know that what is the immune status. In terms of the intrinsic vulnerabilities you might have based on the past medical history, we can say that there is a alcohol usage involved, which is chronic and which is significant, which might bear relevance, because we know that if you just like big picture, rather than coming to individual diagnosis, that what does alcohol use entails, right? That it entails the damage to your liver, to your GI tract, to your cardiovascular system. And we could imagine that how all 3 of them might be at play in current scenarios, right? And whenever you hear abdominal distension, which has been going on for a few months, the real question is this, that is it telling me about some impending dysfunction? Because abdominal distension, with it, like unless you are talking about bowel perforation and acute peritonitis or hemorrhagic ascites, there is not much which can acutely kill you when there is abdominal distension. So what I'm trying to understand is that this abdominal distension, which has been going on for 2 months, what kind of dysfunction in the body it represents? Is it representing the excessive accumulation of fluid in the peritoneum because of, let's say, portal hypertensive physiology? Is it representing some degree of dysmotility affecting the colon, and maybe it is the accumulation of the GI tract contents like stools itself which is doing this, right? Or is it something more than that, and maybe we are talking about the organs themselves getting bigger or something occupying the peritoneum which is not supposed to be there, right? So we will try to understand that as we get the more labs and more imaging. And having said that, if we now try to layer that on to the shortness of breath, which is going on for last 2 weeks, like one reflex thought one might say is that is it possible that whatever physiological process is going on in your abdomen, maybe mechanically itself, it is exerting the pressure on your diaphragm, and maybe that is the reason why you are having hard time breathing. But the other thing which you have to keep in mind is that it may not be anatomically related. It may be more physiologically related. So for example, you have something going on with your liver, maybe which ended up causing portal hypertension, maybe it ended up causing bleeding in your GI tract, which we knew because of the black tarry stools and the physical examination. And it's the hematological issue, like the anemia, which is making you short of that, right? So that is one way to link those two findings. And then finally, if you focus on the examination findings, and I will love for Rabih to tell us more about the subtleties that just this combination of having evidence of cardiogenic shock in a sense that your blood pressure is on the lower side, you have elevated jugular venous pulsations, maybe some valvular processes which you are taking care of. But at the same time, you look maybe on the drier side, that you are pale, because how many times you have seen someone in like heart failure state with lower blood pressure? Either you expect that when you are in the later half, like maybe you have burnt out kind of heart failure, that your EF is like 10%, right? But in general, if heart failure has been there for a while, you don't expect blood pressure to be that low until something critically happens in your valvular structures, right? So in this case, that combination is very unique. That why do you have blood pressure on the lower side but still have evidence of heart failure? And one subtle clue might be in the fact that we are seeing the evidence of active GI bleeding. And if the GI bleeding was severe enough, was bad enough, then we know that you can go into hyperdynamic circulation because your body is trying to compensate for it. And maybe that is the reason why this gentleman has the lower blood pressure, but at the same time has overt clinical evidence of heart failure as such. So, like big picture, we want to understand what is going on in the belly, why it is getting distended, how that physiologically might end up causing bleeding, and how that bleeding might influence your shortness of breath by affecting the cardiovascular system in indirect means. Curious to hear your analysis, Ravi.
Kirtan, I'm right there with you. I think that my mind was tracking the data so eloquently presented by Manaswini as if we're there as per usual. And then I can't think of anything beyond what you just ended with because it's such a critical finding. And as you said, we have arterial hypotension here. And whenever we have arterial hypotension, we're asking ourselves, is there venous hypotension or venous hypertension? And I think here with the distended neck veins, we've essentially diagnosed that there is a problem from the blood going from the veins where it is stuck and distended, making it over to the arteries where it's empty. And the question is, where along that pathway between the transformation of venous circulation to arterial circulation is that flow reversal not happening? We hope that it's in a large chamber like the LV, because a large chamber has a lot of reserve and can try to adapt and function around that. But if it's a specific point, like a large pulmonary embolism, the ability to adapt around that is much less. So I think we're trying to figure out what is the difference between those, where is the lesion fundamentally, but at the same time, you have evidence that there isn't just a blockage of flow between the vein and the arteries. You have evidence that the arteries are being emptied by the presence of anemia here. Of course, we haven't proven that this is blood loss anemia. We're suspicious of it based on the change in the stool, but the patient could have anemia of other mechanisms, which would be important, but maybe not as sinister as blood loss anemia. So yeah, I think you now have to put everything and reorder it and focus on the patient's hemodynamics and use everything else as a clue to understand what's happening. But yes, you are in a very critical situation of what looks like a cardiogenic or pericardiogenic shock with concerns for blood loss. And so I think the next hour of evaluation to understand the status of the lungs, the status of the liver, the kidney, the hemoglobin will be very, very important. I can see why this case resolves in 4 aliquots. I'm not sure the patient has time for more, but we'll see what happens the next one.
Awesome. So here comes the second aliquot. So his labs, his hemoglobin was 4.15, baseline of 13, which was checked 1 year ago, and hematocrit of 13.5, platelets of 12,000, and MCV of 112. Total leukocyte count of 10,860, neutrophil 34%, lymphocyte 55%. And so we managed him by admitting him and then giving him IV Lasix. And we also transfused 2 pints of PRBC. And the patient's symptoms actually worsened with some increased difficulty in breathing, and the blood pressure further dropped. but we managed it with some inotropes and low dose diuretics. So the patient improved over the course, and the symptoms that were developed subsided. However, the patient persisted to have the anemia and also was having some hemoglobin drop. It had improved to 7.8 over the course of 2 days, but it dropped to 6.2, and with some persistent thrombocytopenia. So over the span of 2 days, there was transfusion of 3 PRBC, 4 random donor platelets, and 4 FFPs. And on the second day, he started to develop some altered mental status and also this blackish discoloration that I will share. And we'd love to hear your thoughts. Is my screen visible?
Extremely visible. Oh my God. Oh man, that's really wow. Yeah, Kirtan, I don't want to steal your thunder. What are your thoughts?
Yeah, that'd be very scary situation that as we were contemplating in the first episode, oh, why Manas when decided to present this way, that patient doesn't have enough time, and looks like that he gave some blood transfusions because the hemoglobin was critically low. And for all intents and purposes, it's fair to say that maybe the hemoglobin could have been low from the bone marrow process as well. We are not sure, or maybe peripheral consumption, but for sure there was a component of GI bleeding as well because patient continues to have the tarry stools, and despite transfusions, you're not able to keep up, right? And unfortunately, despite giving transfusions, patient worsened because again, we are in that critical physiological state. I believe like the critical care physicians might be dealing with such scenarios on day in and day out. That paradoxical, right? That at one point you are wondering some sort of hypovolemic slash hemorrhagic shock because you are bleeding actively. So that's why you think that we need to give them fluids. And even if we are not giving them fluids directly, we are giving them blood transfusion, which is a fluid in a way. Like you are giving, like when you give one pack, it's like about 400 to 500 ml itself, right? And this gentleman is not just receiving RBCs, but also receiving platelets. And if your heart is not doing well, then you could imagine that excessive volume which you are giving to correct the hypovolemic physiology is now impacting your cardiogenic physiology, right? So very tough situation. And maybe that is the reason why Manaswini's team was compelled to give some degree of inotropic support as well, because there is nothing else which you could do in the real time, right? And another important question in this case would be to understand that what is going on in the heart itself. Is heart just an innocent bystander due to severe acute physiologic derangements? So, for example, in hyperdynamic circulation as such, your heart is fine, but it's the metabolic dysfunction which is driving this. Like you have something which is causing severe peripheral vasodilatation, you have breakdown of the metabolic machinery at the level of cells, maybe which is the reason your heart is trying so hard, or you have so less hemoglobin as in this case, right? Versus, do you have intrinsic heart problem? Like being in this age, if this was a 20-year-old healthy person, then you might say that, okay, maybe I have less worry about the heart being involved as well. But in an older gentleman, you also worry that is the heart intrinsically involved, maybe because of the like ischemic dysfunction, or maybe the intrinsic myocardial dysfunction in some sort, right? And we will try to establish that down the line with more physiological parameters, right? Having said that, now what to do with the screen on front of us right now? That after giving transfusions, patient is noticing this black discoloration. So when you see the black discoloration, of course, there are so many ways to approach it, but one easy way to think about that is that maybe you are seeing that there is some degree of ischemia to the peripheral parts of your body, right? Because we know that the acral blood supply is always the most critical and is always the most jeopardized easily because your body tries to vasoconstrict whenever it gets a chance. And in our case, for all intents and purposes, we are dealing with those physiologies in which you get peripheral vasoconstriction. We are not worried about distributive shock in any ways, which could cause peripheral vasodilatation. So in most of the scenarios, when you have cardiogenic shock or when you have hypovolemic shock, you are talking about peripheral vasoconstriction. So you have low blood in the system itself because you are bleeding. And on top of that, not sure how good your heart is able to pump. and your body is trying to compensate by peripheral vasoconstriction. So by all these three mechanisms, you are compromising the blood supply to your distal extremities. So one might say that, is it possible that what I'm seeing is the evidence of ischemia, and maybe this is the early onset necrosis, right? So this is one hypothesis, and the alternate hypothesis you might entertain, but and you need to entertain it simultaneously because both are critically important. That what is the mechanism of platelets being low in this case, right? That if your platelets are low from, let's say, you have a massive splenomegaly, or let's say your bone marrow is not doing its job, then you are not that worried about those kind of platelets being low, but you are more worried if platelets are low because of shearing going on somewhere in the body, right? So what I will try to understand is that, is this a consumptive thrombocytopenia and what we are dealing with is a TMA kind of process, or am I dealing with just the bone marrow effect that everything is low because of some unknown reasons which we are not sure, right? And we haven't even employed our cognitive energy to figure out that where the platelets and hemoglobin, like why are they low, right? Because right now we're trying to fix, like save this person's life, right? First you need to support him, then you figure out what's going on. But in this case, unfortunately, we have to do the workup simultaneously because a very unique combo, right? That your heart is not doing well, you are bleeding, but then your platelets are low, and that is not helping you with the bleeding, but you are not sure why the platelets are low. Now, Manaswini hasn't told us the baseline of this person, but imagine that even if you are alcoholic, and even if you might have cirrhosis, even if you might have splenomegaly because of portal hypertension, in general, the thumb rule dictates that if your platelets are going below the 50 or 40 mark, then don't assume it reflexively that this is just because of alcohol itself. You will see many people who have alcoholism, portal hypertension, who might have platelets chronically in the range of maybe 80s, maybe 90s, maybe 100. But when it goes below 50, you have to do your due diligence and always worry that maybe alcohol is not helping, but is there something else which is driving these platelets to be on the very lower side, right? So I'm trying to understand that process, that what is the mechanism of this anemia thrombocytopenia, and is it causing some degree of thrombotic occlusion in the peripheral extremities, or this is just because of the vasoconstriction and hypovolemic physiology. So curious to hear from you, Rabi. Very complex case.
Yeah, I agree with you. I think that there's a lot of things to analyze, and I think, all I will try to contribute is to try to make this case more digestible for those of you who are at the beginning of your journey. And I'll tell you that you sort of have to ask yourself, of all the things that Kirtan outlined, what do you focus on right now in this moment? And I think you have two simple problems to address in the moment, which is that the patient is not perfusing all of his organs, as is likely true by the combination of soft blood pressures, tachycardia, and then, of course, inotropic dependence. So every organ is a threat, but we're seeing that there's a disproportionate consequence on his skin. And I think that's because our interpretation of the images that Manaswini is saying is that he has distal ischemic changes with associated likely hemorrhagic bullae. So everything else, if you can tackle these things, if you can't tackle these things, then everything else is not going to be prudent to solve because, again, this is about the whole body and then the limb. And everything else is just giving you clues as to what's going on. So you might ask yourself, why is the skin? We already talked about the heart, right? What could be going on in the heart, either a focal blockage or a chamber-based dysfunction. So you might even ask yourself, the first question is, why is the skin disproportionately affected? The patient's ventilating well, seems to be peeing okay. We don't know the status of his liver, which I'm really itching to hear for many reasons, but we'll say that you ask yourself, why is the skin disproportionately affected? And it might be because of the effect of vasopressor. So vasopressors have a disproportionate clamp on the superficial skin vessels, and unfortunately, a very well described rare complication is distal limb ischemia in a symmetric manner. That would invoke the idea that there is vasospasm of the distal artery, which would be a mechanism that is more benign than thrombosis of the distal artery. And you might ask yourself, why would there be thrombosis of the distal arteries? And at that point, you're starting to think, what causes skin predominant thrombosis? And there are some conditions that just affect the skin that are usually related to cold. So patients with cryoglobulinemia, for example, just can get thrombosis of their limbs, but those patients usually have isolated skin thrombosis. This person's accurate problem representation is probably that they have a systemic disease associated with skin thrombosis, and there are three conditions to keep in your mind. First is DIC. The second is antiphospholipid antibody syndrome. And the third is one of my favorite RLR cases. I even remember the number RLR 96. You all should check it out. It's one of the best CT solver cases I think that's out there. And it describes this phenomenon of ischemic hepatitis that releases these funky coagulation cascade, which we can zoom in on, that can cause disproportionate skin thrombosis. And so for me, when you paint a picture of somebody with heart failure who develops this phenomenon, I'm really itching to see what the LFTs are. Because my short list is DIC, ischemic hepatitis, and antiphospholipid syndrome. None of these immediately match the hematological profile at first glance, especially the lymphocytosis, but that's probably where I'd start. There's a lot of work left to be done. The initial layer is why is there ischemia, global and focal? And then the next layer is what's up with the hematological abnormality. Wow, honestly, yeah, a complex case indeed. I'm curious what you have next for us.
Awesome. Mainly why I'm presenting this case is to understand what was happening to this patient better listening to you, and it's just pure poetry. So thank you so much. Coming to the third aliquot. So we got his ion profile, which was a saturation of 63% and a ferritin of 2,200. Retic count of 3 was increased, even the corrected reticulocyte count. And coming to his CMP, this was after the transfusion. So his urea was 103 raised. Creatinine was from day 1 to day 3 was 1.28 to 1.51. Sodium, potassium, chloride were all normal. Total bilirubin was increased from 1.95 to 4.29. With direct bilirubin of from 1.06 to 2.4. Total protein was 5.8 and albumin of 3.2. AST increased from 4 to 795. ALT was from 42 to 583. And ALP was consistently high. INR was raised from 2.55, was raised to 2.55. And his NT-pro-BNP was high as well. D-dimer raised 7.36, and fibrinogen was low, 49, and LDH of 1030, which was raised. And the smear showed dimorphic anemia with moderate thrombocytopenia and nucleated RBC and few microspherocytes and occasional polychromatophiles. We got Coombs, it was negative, and haptoglobin was borderline low. ESR of 12, CRP of 109. B12 normal, folate normal, GGT was raised 114, amylase 212 raised. Lipase was raised as well to 673. Lipid profile normal, and HIV, RPR negative, HCV, HBV, HCV negative. And coming to the Doppler bilateral lower limb, there was some mild edema, but no evidence of DVT. 2D echo showed dilated LA, dilated RA, RV, mild MR, severe TR, moderate pulmonary artery hypertension with a PASP of 57, which is raised. More than 35 is raised raised, and ejection fraction of 50%. USG abdomen was done, although Dr. Rabih wouldn't like that. I'll give you the CT as well. Mild hepatomegaly, mild ascites, bilateral pleural effusion, and some bladder wall thickening. CECT showed mild splenomegaly, hepatomegaly, mild moderate ascites, and there was compression and collapse of T8 and T9 vertebra with multiple sclerotic foci in visualized vertebrae and in some vertebrae and lytic areas in L5 vertebrae. I'll give you the HRCT thorax as well, which was done. And there was patchy areas of GGOs in bilateral lung fields. And there was cardiomegaly with dilated main pulmonary artery. And after this, I would love to hear what investigations you want and your reasoning for that. And yeah.
Honestly, this is absolutely perfect. I was just jumping to say that I'm just going to switch from my laptop to my phone because we're about to work, but I'm here and listening, okay?
Perfect. All right, no worries. Well, Vasuni, oh my God, this sounds like the patient which I admit when I'm on admitter shift. So what happened is that when you're at admitter shift, you have like 12 hours of the day and you end up admitting maybe 5 to 6 patients. Now, what happens is that you don't see interesting patients every day, right? So you know that you're going to get some like bread and butter routine cases, but then once in a while, when you're on admitter shift, you might get a fancy case, right? Now, what happens is that since you're admitter, next day, it's someone else who is going to take over. You're not going to be there, right? So what I do is that as soon as I sniff that something is interesting, I will just like do the blasting of the workup. Like we'll order like maybe 25 tests, so much blood will be drawn that patient's hemoglobin will drop by 0.5 to 1 just because of the test which I ordered, and the nurses will be texting me that, hey, what is going on? Like, are we sure you need all this testing right now? Can you do it some of it at night? And I'm like, not sure about that because tomorrow someone else will come, and what if they don't want the test which I want? So this sounds like that case. That oh my God, they're like, what is this? Like, there's some lytic lesions, there's sclerotic lesions, and then there's some bleeding, and then hematological system is gone. You have like coagulopathy going on. You will order every single test possible. You don't want to wait at all, right? So, like, first, like, to anchor into the problem representation, that what is going on, that in a nutshell, we are dealing with a middle-aged gentleman with very significant alcohol use who is presenting with acute onset hemodynamic derangements, right? Where is the hemodynamic derangement stemming from? We are trying to understand. Is it stemming from the GI tract where you are losing the blood? Is it stemming from the cardiovascular system where the heart is not able to do its job? And third, is it stemming from the hematological system itself at the level of your microvasculature where something wrong is going on and you are consuming all the different cell lines in different proportions, right? So we are trying to understand the interplay of three systems: cardiovascular, hepatological, and hematological, right? And as of now, from the cardiologic standpoint, it seems like there is nothing that we could do much. We are not suspecting that this gentleman has acute coronary syndrome and we need to rush him to the cath lab to find out that where is the obstruction in the coronary arteries. Let me remove that and patient's heart will start beating fine, right? It is not what we are thinking. We are not worried that suddenly one of the valves is gone and you have like acute onset mitral regurgitation or acute onset tricuspid regurgitation. We are seeing valvular regurgitation, but seems like that is a consequence of your heart being trying to beat so fast and probably not having enough volume inside it, so-called hyperdynamic circulation, under which you can see variable degree of valvular dysfunction. So it's hard to say, and it's hard to imagine that you will have a primary valvular process which is going on simultaneously in your mitral valve and tricuspid valve, right? So the fact that multiple valves are involved makes us again think that problem is not in the heart, it's from somewhere else, right? So for a moment, if we remove the cardiovascular system and now we move to the hepatological and hematological and then try to make sense of what's going on, right? So in hematological system, Manaswini gave us all the data, and from all that data looks like that maybe we are dealing with coagulopathy, right? And based on the labs, it seems like that either it is coagulopathy of liver failure, which can mimic DIC, or it is overt DIC itself. Why I am using the word liver failure? Because what we were discussing with Rabih in the previous aliquot, that your AST ALT is starting to go up, your LDH is already on the pretty higher side, your INR is now starting to creep up as well. The only component which we don't have right now to overtly call it or officially call it acute liver failure is the presence of normal mental status. But it could be just a matter of time, right? That who is to say that in 2 hours from now, this gentleman will not get altered, right? And that will help us fulfill the criteria of liver failure. And the another reason why I'm saying this might be in the liver failure is also because firstly, your fibrinogen is low, which is one of the important prerequisites. And look at the ferritin and look at the percentage saturation, right? Now, whenever you're dealing with a complex syndrome, don't put your money on just one set of labs like ferritin or saturation, which could be skewed even by the fact that you got the transfusion, right? But when you are dealing with the liver problems, always remember that your liver stores all the iron in the form of ferritin. So whenever you have acute liver failure or acute hepatocellular injury to the severest extent, as it can happen in people who have severe alcoholic hepatitis or you have background of cirrhosis, often you are releasing everything in the blood and that can end up causing high ferritin, high saturation, right? But again, as I said, it could be skewed by the blood transfusion. However, given the clinical evidence itself of how things are moving, your heart is not doing well, maybe there is some degree of congestion to the liver from your hepatic vein, and at the same time, hepatic artery is also not getting enough blood supply because of the severe shock which you are in, right? So combining all of that, we have enough evidence that, okay, maybe you are dealing with like hepatocellular injury, ischemic hepatopathy, and maybe that is what is driving this coagulopathy. Now, so far, Manaswini hasn't given us any clues which could tell us that there is a sepsis physiology going on, which could be driving DIC. Because what can drive DIC? Of course, there are so many possibilities, but the key aspects are, is it an infection like sepsis and do I need to give broad spectrum antibiotics? Is it the liver failure like in our case? And if only once we have evaluated both of these hypotheses, then we move to the other rare causes. And there are so many of them, but the important one to keep in mind is it a TMA, which is not DIC? And because DIC is also a form of TMA. So is it a non-DIC TMA, which I need to entertain? And we haven't heard about cystocytes on the blood smear, but it may not be sensitive enough. And finally, fourth, are we dealing with some rare kind of hematological malignancy, especially the leukemias, which can trigger DIC and which can also explain why the cell counts are too low. So that is where my mind is at, that what I need to do to save this patient. Do I need to make sure that I get the hematologist on board, try to help me correct this coagulopathy, right? And at the same time, trying to understand that where is this coagulopathy coming from? So that is the hematologist role. And the second aspect, is he still bleeding or not, right? Because if you keep on bleeding from your GI tract, no matter what else you do, you will end up being on the receiving end, right? Because once you bleed, your hypovolemia will set in and the whole system will go in a bad spiral, right? So unfortunately, although it is not ideal, we will need endoscopic evaluation sooner or later to fix that where is the bleeding coming from and then make more progress. So curious to hear from you, Rabih, where is your mind at?
Yeah, Kirtan, I truly have nothing to add. The severity of this syndrome is apparent to everybody involved. We have now liver dysfunction, heart dysfunction, brain dysfunction, focal skin ischemia. And so, yeah, I have nothing to add to that. Just to re-emphasize that, unfortunately, we don't have an alternate explanation for the thrombocytopenia and anemia with a lack of extreme splenomegaly. So a platelet count of 37 would have been a dilemma if the spleen was very big. But now that the spleen is not, I think the answer really lies in the bone marrow and those pesky lymphocytes that have no role here need to be studied with scrutiny, and they may not be lymphocytes after all. So yeah, so nothing to add to your excellent analysis.
Awesome. And thank you, Dr. Rabih, for discussing so eloquently in spite of waiting to board. So thank you. And now coming to the investigations you asked for. So before that, we did get malaria, dengue, scrub typhus, vidal, lepto, all negative. Serum ammonia was raised to 91, and normal complement levels, cryofibrinogen levels normal. Tox screen was positive for alcohol, ANA negative, ENA negative. And he did have some mild altered mental status before, so NCCT was done, and then there was we saw that there was subacute to chronic SDH. And coming to the investigations you asked for, so his endoscopy was negative. It was a normal study, and we did get serum-free light chains, which were raised, kappa and lambda both. And gamma globulin was mildly raised. Kappa by lambda ratio was raised, but there was no M band present. And on repeated repeat protein was 6.9 and albumin of 3.3, which is in the low normal. And coming to bone marrow biopsy, so we did get that. And the peripheral smear showed we repeated a peripheral smear and it showed a leukoerythroblastic blood picture. And on the bone marrow biopsy, the histopath showed cells arranged in singles, clusters, and vague glandular formation, with individual tumor cells being very large, polygonal, with high nuclear cytoplasmic ratio, and prominent nucleoli and scant cytoplasm. So as predicted, it was it said that there was a possibility of metastatic carcinomatous deposits. Curious, and also the patient's condition now was clinically stable and he gradually improved. The DIC had resolved. His liver injury had resolved, but his ALP was persistently high. and his platelets were 1.38 lakhs and hemoglobin of 8.9 and normal WBC. And I would like to share another image to show how his extremity had progressed.
Sure, Manaswini, go for it.
Awesome. So, and this was a picture that I wanted to share, that now he presents with this in his, so the difference is that in his left foot, there is a worsening of the dry gangrene. And that is what we saw. That's how he progressed. And that's what we saw on the bone marrow biopsy. Curious to know what other investigations you want, and that would reveal the diagnosis.
Okay, perfect. Wow, Mercy, like very scary case, right? And as we are trying to discuss, just like so that we don't lose the sight of how did we get here, right? That we're trying to understand that what is going on. Is it the hepatological system? Is it the cardiovascular system, or is it the hematological system, right? And eventually we figure out cardiovascular, probably not the central player. Hepatological could be a player because you might be actively bleeding, and maybe you have alcoholic history, maybe your liver is failing by multiple mechanisms. But looks like that at least endoscopically we are not able to find the evidence of bleeding. And even if your liver might be failing in itself, but the signal from hematological system was too profound, given the fact that we entertain that the degree of thrombocytopenia is out of proportion to what you might expect from the alcoholic effects on the liver and bone marrow itself, right? So something else was going on. And then we said that, okay, what can cause coagulopathy? Is it coagulopathy of liver failure, which looks like DIC? Is it DIC itself from sepsis? But we didn't see anything in the sepsis. And then finally, we were thinking that, is it a hematological process going on? And by that, we meant that something is in the bone marrow itself, which is causing this TMA kind of process, right? And now there was so much data in press record that we didn't even touch upon that. But if you think about the lesions which Manaswini highlighted in the vertebra, that there were some lytic lesions, there were some sclerotic lesions, right? Now, if it was throughout the spine and if there was evidence of osteoarthritis, one might say that, okay, this is not the real deal. But the fact that it was focal and very subtle, it definitely raises a concern that it is a pathologic fracture in a way. And you are talking about a cancer, either hematological or solid, which affected and which went there, right? Now, whether it is a hematological tumor or whether it is solid tumor, we have the pathology. So we don't have to try to think too hard at what it could be. We saw the evidence of classic, what we call as the myelophthic kind of picture, where you have leukoerythroblastosis, which means that you have peripheral nucleated RBCs in the smear, which you are not supposed to see, which can only happen when your bone marrow is filled with something else and you are pushing the things outside. And that is what it's going on, right? Now, what kind of process this could be? So seems like that since this is a gentleman, and then if you combine that with the sclerotic lesions, you are most worried about the metastatic prostate cancer, right? And only once you move past that, you think about other cancers, like think about like breast cancer, which can also happen in males, and you can think about other GI tract tumors. So only these three tumors, and then finally the lung cancers are well known to infiltrate the bone marrow. But with the base rate wise, you would be worried most that could this be a metastatic prostate cancer, right? And curious to hear from Rabih that what is his analysis looking like for this worsening skin lesions.
I think your analysis is absolutely superb. I think that, yeah, your heart sinks for this situation because as we, yeah, Jess, I wish it was. It's not. But thank you for making my fight so much more special now. I can pretend to be in one. Um, but anyway, for those of you on YouTube will not have no idea what that meant. But that's why you have to join live. Um, yeah, I'd say that, we started off with like a little bit of abdominal distension and some shortness of breath, and look where we are now. It's really sad for the patient. I think that you latched onto the most powerful abnormality, Kirtan, which is that it's very easy to disregard the value of bone lesions in somebody with bone marrow disease. I think because the bone and the bone marrow are next to each other, we instinctively say whatever's causing the bone marrow disease is causing the bone lesions. But actually, the bones and the marrow are too far apart and too separated for that to be the case. And when you look at it, the most common cause of a bone marrow issue and a bone lesion at the same time is multiple myeloma. That is an unlikely diagnosis whenever you have a thrombocytopenia and abnormal white blood cells. And so just that combination alone, when you freeze this entire case and you see the patient has deep cytopenias and bone lesions, the probability of a metastatic solid tumor goes through the roof. And this reflection that I shared with you came from a case that Ethan presented. I'm not sure if it was public or in the academy, where we were all reflecting, realized, wow, like the overlap of bony lesion plus marrow is microscopically small. And I think you pointed out the next layer in the schema, which is what kind of tumor? Does it always have to be bad? And I think prostate cancer, you're right, is the only cancer that has a tropism to cause marrow disease and bony lesion, and not the absolutely horrific in terms of prognosis. Every other possibility even includes undifferentiated, poorly differentiated tumors and cancers of unknown primary. And so I think I'm waiting with bated breath to hear about what the PSA is, because that's the only hope of a decent prognosis for the patient. I do think that we should acknowledge that as teachers, the elements of the heart and the liver remain not fully explained. But once you generate the idea that the patient has such the possibility of an aggressive tumor, the complications on the heart are through the roof, including the possibility of merantic endocarditis, which, given the valvular lesions we have to entertain, the possibility of tumor thrombotic microangiopathy in the pulmonary circulation, which is very plausible given the pulmonary hypertension on the echo. And for those reasons, the heart failure and then the skin failure, I worry more so that the cancer is more sinister than the prostate. And the reason I say that is that when prostate cancer develops this phenotype, it tends to cause a hyperfibrinolytic DIC, which means that the DIC tends to be more in the bleeding category than the clotting category. And so the presence of thrombosis, possibly on the valves, possibly in the pulmonary artery, and possibly, and certainly, I should say, in the skin, has me worried that the PSA might not be as high as I would like it to be, and that the patient may have a carcinoma that's actually originating in the liver, given the alk-Phos elevation, or of an unknown primary. So, I think there's nothing business class about this VMR at all, both in terms of where I'm sitting and in terms of the concern I have for the patient. Any final reflections to layer upon that, Kirtan?
No, Ravi, I'm also curious to see that where is this cancer coming from. Hope it's not from GI tract. Yeah.
Everything about the discussion is business class or even first class. Absolutely loving it. So we did get PSA, and it was luckily 135 raised. And worried about what Dr. Rabih was saying, we did get a PET scan as well. And the PET showed slightic and sclerotic lesions involving the skeleton, especially the sacrum. And there was some hypermetabolic bilateral axillary lymphadenopathy, but no evidence of primary another neoplasm, or no evidence of hepatosplenomegaly, no evidence of lesions in the liver or spleen. But this was an FDG PET, and we did not get a PMSA PET. But it was, and then we did get a CEA, C899 as well, but those were raised. Not sure how important it is to get them. And then finally, we did decide to get biopsy of the prostate. And on immunohistochemistry, it showed 4+ for CK, and 4+ for something called NKX 3.1, which was positive, and that indicates a metastatic form of the prostate cancer. And there was also AMACR, which was negative, but that also indicates some metastatic prostate cancer. And then coming to the histopath report of the biopsy. So it showed a CNR adenocarcinoma in the left lobe of the prostate, with a Gleason score of 4+3, which was a grade 3 and stage 4 prostatic adenocarcinoma, induced TMA plus DIC, or would like to hear your thoughts on what you think might have happened. And the right lobe was normal. So we'd love to hear your thoughts.
Well, lucky for us that at least it's the prostate cancer and we can breathe easily. Imagine if this was a pancreatic cancer or gastric adenocarcinoma with Trosue phenomenon DIC. Unfortunately, the prognosis is so poor that you could barely make it to the 6 months. But with prostate, there's still hope that you can survive for a few years, right? So, like, at least in terms of anything which is loose ends in this case, nothing which comes on top of my head right now, because we are able to clear the heart of the hook, that nothing is intrinsically wrong with the heart, nothing is wrong with your GI tract itself that you are bleeding. So it was just a process, it was just a matter of consumptive coagulopathy kind of process, which unleashed its insult on various other systems. So the center of gravity was in the hematological system. And with that leukoarystoblastic picture, the bone marrow biopsy, and the concurrent histopathological findings from the prostate itself, it makes up for a good case. And regarding the thrombosis and everything which was going on, so that would love to hear from Rabih, that could it be just secondary to like what we were discussing earlier, that diffuse ischemia from the hemodynamic derangements, and on top of that maybe some degree of like microvascular occlusion as well due to thrombotic component of this DIC kind of picture, and maybe hopefully the patient will improve as the hemodynamics improves, right? What do you think, Rabih?
Yeah, I'm right there with you. I think this is a we've had the luck in Kirtan of consuming cases of a similar theme, maybe 5 times in total on VMR, and knowing you maybe 500 times in your case report reading. But it's a very difficult case in real life to understand. I hope, can you guys hear me okay? It's a little loud. Can you hear me okay? Okay, great. Yeah, I think that if you try to analyze this case from the diagnosis and explain everything going forward, it's not so hard. Here is what my proposal would be. Patient has an aggressive form of prostate cancer, acinar adenocarcinoma, and that tumor has a strong propensity to go to the bone. That is not hard to explain. That causes a high alk phos elevation. Very rare, in a very rare number of people, about 5% of patients with a metastatic prostate cancer, the bony elements extend beyond the bone and go into the bone marrow. This infiltrates the bone marrow, causing cytopenias, and curiously unleashes a DIC pattern. And the idea fundamentally is that when the tumor cells interact with the marrow cells, the marrow is allergic to the presence of these tumor cells, and it triggers essentially consumptive coagulopathy in the manner no different than when a bee stings me in the middle of the desert, in the middle of the jungle in Puerto Rico. But anyway, that's a story for another time. And so the patient unleashes a DIC, and I think you have overt evidence of DIC by the hypofibrinogenemia, by the elevated D-dimer, and by the thrombosis that is present in the skin. The interesting thing is that if you look at patients who develop this kind of prostate cancer, most of them tend to bleed more so than they clot. And so I'm going to read a little bit more about this thrombotic manifestation. And so the question is, what is left unexplained by this sequence of events? The limbs are explained, the hematological abnormalities are explained. The heart is the mystery. And you might ask yourself, why is the heart so dysfunctional that it failed? And I think that's where you might say, well, I know a way or several ways the heart can fail from thrombosis. The most common way, of course, is acute coronary syndrome. If somebody gets a massive myocardial infarction and then suffers consequences of that. But there are two other locations where microthromboses can cause heart failure, and that's on the valve. When you microthrombose around valves, you get valvular heart failure and what's called merantic endocarditis. And the other way you can have other places is in the small pulmonary arteries called tumor microthrombi. So for me, I think the sequence of events is prostate cancer goes to bone, goes to marrow, unleashes a DIC that causes clots everywhere in the skin, in the pulmonary circulation, on the valves. And then that explains everything that you see, unfortunately, for the patient. But you can imagine that disentangling that and seeing that from the very beginning is very hard. Because what do you see first? You see the combination of heart failure and skin ischemia. That's the first thing you see with your own eyes. Elevated JVP, soft puncture, skin ischemia. Like, how do I suspect that diagnosis just from the get-go? And I think that's really, really hard until the platelet count comes back. Because when you have thrombocytopenia and thrombosis, the possibility of those things overlapping is very minimal and includes essentially microangiopathic hemolytic anemia, which is ultimately the clincher here. So for me, the fastest way to think through this case is to see heart failure and thrombosis plus thrombocytopenia, to worry about a microangiopathic hemolysis. And coagulopathy, the low fibrinogen makes you think DIC. Unfortunately, subacute DIC is cancer until proven otherwise. So very, very difficult journey that we had to go through, and had to be very, we had to sweat along the way, but I think it was a really, really rich one. And I'm very, very grateful for Manaswini for such an incredible thing. I'm curious what reflections you have, Manaswini, and for Kirtan the same.
Yeah, Manaswin, you go for it. Tell us, how did you learn about this case? How did the patient do in the end?
Yeah, so this patient was pretty frustrated because we told him that he might need chemotherapy for stage 4, and he just wanted to go back to work. But the friction here was, for me, is this because of I thought it might be because of the blood transfusion itself versus what happened before, like it could be DIC plus TMA. And the fact that like it was Coombs negative hemolysis with like leukoerythroblastic and bone marrow infiltration. It could be TMA, but also DIC. I think that was something that I still I don't have enough clarity about. But yeah, and the other thing is, so yeah, he was exploring his options for treatment, and we think androgen deprivation with some chemo and targeted androgen receptor therapy is something that they wanted to start. And yeah, he's in the process of that. So, and I'm really grateful to Dr. Rabih for discussing on the plane, because on the plane, it's usually hard to even call my parents and say the plane is taking off. But Dr. Rabih was insanely amazing discussing a case with so much clarity, and would love to hear your thoughts, Kirtan.
Yeah, no, like what Rabi said, like that is how it is, that often it's hard to disentangle every pieces of the puzzle. And like from what I have seen, like on oncology wards over years, is this, that since, like, imagine diffuse large B-cell lymphoma. It is so common, it presents in so many varied forms. So similarly, like initially we used to think that myelophthisis or this bone marrow carcinomatosis is very rare. But over the years, people have realized that if you end up doing histopathology for variable reasons, you will find that so many people have like subtle deposits of the tumor in their bone marrow, right? So given the fact that prostate cancer is so common, and there are disproportionately elevated cases of myelophthisis from this cancer because it's just so common, you can see variable forms of it. So like all the variants which Ravi mentioned, like I have seen at least once, all of them, either in real life or in like case reports, that someone is bleeding, so like hyperfibrinolytic DIC, someone is like clotting and infarcting all the organs, so kind of thrombotic predominant, and sometimes somewhere in between, right? So it's often hard to tease apart with clarity that what could be going on. And as you could imagine, that all these diagnoses like meningic endocarditis or pulmonary tumor thrombotic microangiopathy, many of them are unfortunately made at the autopsy, because like in order to make the diagnosis of pulmonary TMA, you like need to wedge your catheter in, you need to take some tumor samplings from the pulmonary veins. So something which is often not feasible unless you are at like very advanced centers where there are enough resources, enough experienced people, and often people are so critically sick. So that is why it's like very hard to like say with absolute like confidence that what could be going on. But in such scenarios, pulmonary TMA is like perfectly possible. So yeah, that is what Ravi eventually taught us. Ravi, anything else before we pass the mic to Austin for teaching points?
I think we're in good hands with Austin doing the teaching lesson. What a real treat. I would say that, Manaswini, I appreciate your kind words. The only reason I was able to do today was because I didn't need to be here and was just sprinkling in some fancy smancy stuff at the end of Kirtan's excellent discussion. I just wanted to say a big shout out to Eugene. Today's scribing required some monstrous skills. So it was really cool to see that. One final pearl that I'll leave you all with is to study the fact that 95% of patients with cardiogenic shock, what this patient have a low EF. 95%. So when you see a situation where you have cardiogenic shock with an EF of 50%, you have to ask yourself, what causes that? And obstructive cardiac disease is the only remaining explanation, where you have either pericardial obstruction or pulmonary obstruction. So from that lens alone, when you put a probe on this person who is in cardiogenic shock and you don't see an EF that's low, you have to search for obstruction, obstruction, obstruction. And that might be another efficient way to solve this case, is you see that there's no low EF, where's the blockage? You see a blockage in the foot, and you might ask yourself, is there a blockage somewhere in the heart? So as you can see, this case is continuing to pour in the reflections from me. I'll let you all be as I pass this plane flight in gratitude to Manaswini and Kirtan for a lot to think about for this 4-hour journey. And I'll hand the mic to Austin for keeping them.
All right. Thanks, everyone. Really incredible case, Manaswini, and discussion, Kirtan and Ravi. And many teaching points that for the sake of time, I'll just pick the ones that I like the most. So sorry for those that don't like these ones. So whenever you have multiple concerns, it could mean that there's multiple time courses. So really just make sure you're striving for clarity when you encounter different conditions to ensure that they have the same time course. In this case, this really bore fruit, and I think we've seen this in other VMRs, but disproportionality should not be regarded. If Kirtan and Ravi and Manaswini hadn't really thought hard about the thrombocytopenia, you can imagine that the diagnosis could have been delayed pretty significantly. So that's really powerful. And then expected physiologic response to stress requires like the baseline reserve to be adequate. So if you don't have adequate reserve to begin with, the consequences that you see in this patient can be really prominent. So I think in this particular person, there's probably prostate cancer that had been brewing. And so on top of that and how it affected the cardiac function, as we've talked about in this case, was really, really a powerful clue. And then disproportionate skin involvement in systemic disease to prioritize, DIC, APLS, and then ischemic hepatitis, as was taught. And then Lyra posted in the chat about the solid malignancy metastasis formula. So it's a bone marrow lesions, which can be implied by the alkaline phosphatase, bone marrow involvement in the form of cytopenias, and then subacute chronic DIC that was discussed. So thanks everyone for joining, and really, really incredible case and discussion.
Perfect. Thank you so much, friends. And Austin, like I was just going to say that fresh hair, fresh beard, fresh and sparkling mind for teaching points. We love it. Thank you so much for amazing end to this beautiful VMR, and thanks to everyone in the chat as well.